This topic is acute pancreatitis. Pancreatitis refers to inflammation of the pancreas, and when the pancreas is inflamed, this can lead to dysfunction of normal pancreatic activity. The primary function of the pancreas is to release digestive enzymes into our digestive tract to aid in the breakdown of fat and fat-soluble vitamins, as well as releasing insulin and glucagon to help regulate our blood glucose levels. Pancreatitis can happen one of two ways. The first way can be from direct injury to pancreatic cells, from things like alcohol, viruses, and even some medications. The second way is from obstruction of the pancreatic duct. This can happen from biliary stone obstruction, as well as mechanical obstruction from a tumor or even a pseudocyst. When the pancreatic duct is blocked, this can actually trap enzymes within the pancreas itself, leading to autodigestion of pancreatic tissue. You can almost think of this autodigestion like a pancreatic suicide. The pancreas is making its own enzymes that are leading to autodigestion of its own tissue. Regardless of the process, pancreatitis can lead to impaired exocrine and endocrine function. Two of the most common risk factors for the development of pancreatitis are alcohol ingestion and gallstones. So alcohol ingestion is going to lead to that direct injury to pancreatic cells, while gallstone presence is going to lead to obstruction of that pancreatic duct, which again is going to trap those enzymes within the pancreas. Additionally, certain medications such as thiazide diuretics, certain viral infections, as well as direct trauma to the pancreas can lead to inflammation. Clinical features for acute pancreatitis include severe abdominal pain after eating. Now, this pain is mostly going to be located in the epigastric region or upper left abdomen. We can also see this pain referred to the back, as the pancreas is located behind the stomach and almost directly against the back muscles and the spine itself. You may notice when clients with pancreatitis are laying down flat that they have an exacerbation of this pain, as the pancreas is in direct contact with those back muscles and the spine. To relieve this pain, you may see patients lean forward, sometimes in a prayer position, which helps to bring the pancreas forward to relieve that pain. Because of its role in digestion, when the pancreas is inflamed, we have difficulty processing foods within our diet, so we can have significant nausea and vomiting. Routine laboratory tests will show an elevated lipase and amylase level, often 3 times greater than the normal value. These enzymes are found within the pancreas itself, so when that pancreatic tissue is destroyed, it becomes released into the blood, and we're going to see those elevated values. CT scan is also a common diagnostic tool, as this will show pancreatic inflammation, as well as the presence of any complications such as pancreatic pseudocyst or abscess formation. Before we talk about complications that are specific to pancreatitis, it's important to note that anytime there is significant inflammation within the body, we can have systemic effects. What do I mean by this? Well, anytime significant inflammation occurs, we can have release of cytokines, which can lead to increased capillary permeability as well as vasodilation. Pancreatitis itself is a risk factor for the development of systemic inflammatory response syndrome, which can lead to things like hypovolemic shock due to third spacing, again, that leaking of fluid from the blood vessels. We can also develop acute respiratory distress syndrome, or ARDS. This is when blood vessels begin to leak fluid into the lungs itself, and causing a buildup of fluid within the lungs can decrease gas exchange. Another significant complication of pancreatitis is the development of retroperitoneal hemorrhage. As pancreatic enzymes are released from the pancreas, this can lead to digestion of blood vessels that surround pancreatic cells. When those blood vessels become digested, this is going to lead to hemorrhage, and we're going to see ecchymosis, primarily in the flank or even the periumbilical or umbilical region, which is referred to as colonsign. Hypocalcemia is another complication that can occur. As the fat that has been stored within the pancreas becomes digested, it becomes available to bind with free calcium in the body, which can lower our calcium levels and lead to manifestations of hypocalcemia, such as Fostek's sign or Trousseau's sign. Lastly, it's important to note that because we have these beta cells within the pancreas which release insulin, if those beta cells have become damaged significantly, we can develop hyperglycemia. Nursing interventions for acute pancreatitis are going to focus primarily on pain management. Pancreatitis causes significant pain, so oftentimes we'll see that this patient is going to be started on some IV opioid medication. To prevent any complications due to third spacing as well as dehydration, we want to start the client on IV fluids and give them antiemetics as well. We should keep the patient NPO, not only to prevent any further vomiting, but also to prevent stimulation of the pancreas, which will lead to additional pain. Once we have pain generally managed, it's important to begin the process of discussing alcohol cessation with the patient, as alcohol is a contributing factor to the development of pancreatitis. We should monitor for the presence of hyperglycemia and give insulin as needed for high blood sugar levels. And we should make sure that we're monitoring calcium levels and address any hypocalcemia that we observe. Thus far, we've primarily touched on symptoms and findings associated with acute pancreatitis. So let's focus on what happens with chronic pancreatitis. With chronic pancreatitis, we have a repeated inflammation of the pancreas, which can lead to the development of fibrosis or hardened tissue that builds up within the pancreas itself. Again, the most common cause that we're going to see for this development of chronic pancreatitis is going to be the use of alcohol. Chronic pancreatitis refers to everything that we've seen before, except this is a repeated process that leads to fibrosis of the tissue, as well as calcifications from buildup of the fat and calcium that accumulate within the pancreas itself. Alcohol is going to be the most common cause of the development of chronic pancreatitis. And while major manifestations of chronic pancreatitis are similar to acute pancreatitis, such as the development of abdominal pain, with chronic pancreatitis, we're going to see this pain be a little bit more episodic. We're also going to see what happens when we have a depletion of those pancreatic enzymes within the digestive tract over time. We may develop malabsorption. Again, pancreatic enzymes aren't going to be able to help in the digestion of dietary fat and fat-soluble vitamins. This is going to lead to steatorrhea, or the development of fatty, foul-smelling stools. We're going to see weight loss. And we may even see the development of diabetes mellitus, as we have that destruction of the beta cells within the pancreas, and we have that depletion of insulin that's available to the body. Because alcohol is the most common cause, one of the first things that we're going to do for patients with chronic pancreatitis, again, is to encourage that alcohol cessation. If hyperglycemia is present, we're going to treat it with insulin. And we're going to encourage small, bland, frequent meals that are low in fat, again, to help with the digestive process. Along with these changes in diet, we're going to want to give the patient pancreatic enzymes. This is going to help break down any of the fats that they do ingest, and they want to make sure that they take these pancreatic enzymes with a meal or with snacks. We're going to observe for the efficacy of these medications by observing for that steatorrhea and seeing if it's still present. Lastly, because of the dietary issues these patients face, we want to give supplemental vitamins and minerals to prevent any deficiencies.